Yeah, hello. Good evening, everybody. Now
Hey,
I cannot unmute.
you're
Sorry,
unmuted.
I cannot reply. Yeah, because I cannot unmute myself though.
Yeah, we can hear you now, Ruli.
Yeah.
Okay, thank you.
Really, how are all the preparation going for December? How the preparations are going for December?
We seem to have lost Ruli again.
You can unmute.
Yes.
Well, shall we get started?
I think we can start. Who's going to be the first? Doug or
Whatever.
Ruli? Okay.
If somebody could share the PowerPoint, I've got computer issues. It looks like somebody needs to unmute Ruli again.
I think you must do that.
And can we get get the PowerPoint up? Is somebody trying to please get the PowerPoint up so we can get started?
Hello. Yeah. Now I'm co-host. Yeah, I cannot. I can unmute now. Yeah, the
Okay.
preparation is good, Facilis. It's working well. We are waiting for all of you come here. Thank you.
Okay. All right. Can we get started? We need the PowerPoint up.
Yeah, maybe Imad, please share the PowerPoint.
Can you see
Okay.
the slide, sir?
All right. Yes, we have it now.
Okay.
Okay. Somebody needs to advance the slide.
Sir, who is going to present?
I mean, I can start discussing, but I can't advance the slide.
Sir, you can tell me to do the go on the
I
next
just
slide,
did.
then I'll move.
I just
Yes.
did.
Okay.
All right. So this is the history of the case that's been provided to us. 61-year-old woman, history of multiple back surgeries, the most recent done about 2 years ago. An L2 to 5 instrumented fusion. She's complaining of persistent low back pain, L4-5 region, bilateral leg pain, and persistent claudication. Out of this history, there's still a lot of information that we need, which hopefully maybe we can have somebody to do it. But anytime you're looking at somebody who's had a previous surgery, I think the crucial things you have to look at is what were the surgeries? What were the symptoms that led to the surgeries? What were the results of each of those surgeries? Did the index symptom get better? Did the index symptom get worse? Did it create new symptoms? Because all of this is information you need to decide what the reason this person is hurting at this point in time is. Okay, can we go on to the next slide? So basically a normal physical exam. Again, what's missing here is crucial thing in anybody who's had a fusion surgery is what is their alignment? Are they in sagittal balance? Do they have normal lordosis? Do they have normal kyphosis? This has to be part of every physical exam. Now, looking at the x-rays here, there's several things that I see that jump right out at me. One is this is not normal alignment. This alignment is not normal. She is very hyperlordotic from L4 to sacrum. She actually has, if you measure her lordosis between the sacrum and L3, which is where 2/3 of your lordosis should be, it's actually over her pelvic incidence, which tells you that there is another deformity going on here. And at a minimum, this person needs scoliosis x-rays to know what their overall alignment is, because that is going to that's going to be very important in anything you're potentially going to do here. So here's the MRI, and it's difficult to, when you put multiple panels like this up, it's better if you're putting these cases in to just put selected views. But basically what you can see, a few things that jump out at me. One is that the L5S1 disc and the L4-5 disc are very close to normal in their appearance, which makes me wonder why 4-5 was even included in a fusion here. There's some increased signal in the L2 vertebral body, indicating that there's probably been a recent, and it looks morphologically like a recent compression fracture there, though those aren't the symptoms we're getting. Severe L5 foraminal stenosis seen in the sagittals. Next slide. Okay. So a few things jumped out at me when I looked at this CT scan. First off, if you look carefully in the axials, there are halos around every single screw, which means that there is no fusion here. Although they did an instrumentation, there's no level that actually fused. So you're dealing with a multi-level pseudarthrosis. The other is if you look down the bottom, in the way it's looking like here in the bottom, it's not quite there. Anyway, the right-sided rod is long and is actually in the sacrum. So and has actually got a halo around it. So the level that is moving is the rod is impinging the sacrum, which would be painful in and of itself. Anybody else? I have comments they want to add. No. So the questions were being asked: should the screws be removed and reinserted? Should we augment with cement, and should the construct be extended? And I guess the question. So first, we have to figure out what the symptoms are from, to decide what to do. We've got several problems we've identified. There's problems with her alignment. She definitely has pseudarthroses at multiple levels. In terms of cement augmentation, we don't know what her bone density is. She's 61. There's a reasonable chance that she's got bone density, and that can easily be done just by looking at Hounsfield units off the CT scan. Take an uninstrumented level, define an area in cancellous bone, encircle it, and using your PAX tools, you'll come up with an average Hounsfield units. And if the average Hounsfield units is under 130, they are osteopenic. If it's under 110, they are osteoporotic. So I wouldn't consider augmentation unless they were osteoporotic. And even then, I rarely do. Am I going to be the only one talking here this morning, or is somebody else going to add in a bit?
Yeah. I think the information about the symptom is not complete yet. I think we have to find more information about the low back pain itself, and we have some option here. Does the pain caused by the pseudoarthrosis? We don't know yet, and uh, but also, does the pain caused by the hyperlordotic position, the stiff of the spine itself, or the pain is come from a segmental level from the narrowing of the foramen? So we have to investigate more, I think, to find the cause of the pain. Uh, Regarding the taking out of the screw, I agree with Dog that I don't think we have to do it now to take the screw, because although the screw make pseudo arthrotic even, but the screw position is good. I think it's quite good, even though the fusion is not happened yet. But sometimes the fusion is not only depend on the screw itself,
Well, no.
and
Once you have established halos, a fusion is never going to happen.
yeah,
So
yeah,
and this surgery was 2 years ago. Fusion is going to happen within 12 months if it's going to happen
yeah,
at
it should,
all.
yeah,
Once you're beyond 12 months. But no, so things to listen for when you're talking to a patient like this. There are patterns of pain. Back pain is not just back pain. There are a lot of
yeah,
different patterns of back pain. The classic pain of pseudarthrosis is pain with loading. So particularly ask them things like how they feel when they first get out of bed in the morning, or when they rise from a chair,
yeah,
or if they rotate. If they're giving you pain in those loading circumstances, then you're probably dealing with pain due to the pseudarthrosis. On the other hand, if you just have an activity-related back pain with standing or walking that goes away as soon as you sit down, that's more a pain of nerve compression, or
yeah,
potentially a pain of alignment. What's really hurting us here in terms of figuring out is the lack of information about what were the results after each of the surgeries. So the other thing to listen for when you're talking to your patient, any patient who has had an instrumented fusion, if they were having pain due to instability or deformity or there should be a symptom improved interval where you've got the spine stable, it's not moving. There should be a time where the back pain symptoms improved if the pain was coming from whatever you were stabilizing. And then what tends to happen is that the pain, if it tends to get in pseudarthrosis, the pain tends to get worse. So they'll have an improved area of about 2 to 3 months where they're not perfect, but they're better. And then over a period, beginning about 2 to 3 months out, they'll start gradually developing increasing pain. So that's what you'll hear in a patient with pseudarthrosis. I'm wondering in this patient, again, because we don't know the alignment, we don't have scoliosis views and we don't have the physical exam. The other possibility here is I am suspicious that she is hyperlordotic to compensate for a hyperkyphosis, and that perhaps the primary treatment should have been addressing the kyphosis. A lot of people with kyphosis as they age will develop activity-related low back pain because they're hyperlordosing and their functional spinal units are not in a biomechanically good spot. So they'll develop back and neck pain, but the primary problem isn't the cervical or lumbar spines. It's that those are hyperlordosing to compensate for the kyphosis. So we really need to see, to be able to make a decision here, you do need to see something to do with her alignment.
There are some comments in the chat room. I would like to say that, if you allow me, of course.
Yes.
Like, since there is a halo around the screws, there is definitely pseudarthrosis. So have a mechanical problem of the instrumented fusion. As you said, that means that we need to check lower and higher from the fusion. That means we need to see the whole pelvis and the hips and the pelvic incidence. And of course, we need to see if there is a kyphosis above. I believe the same. A crucial thing is that it's very, very difficult to make a fusion at the distal part of an instrumented area when the disc is in a very, very good condition, as you very well mentioned, the L4, L5. That would need a cage in order to be able to absorb shocks during the walking and fuse. The other thing is that when you decide to leave the L5S1, especially when this is hyperlordotic, you need to be definitely certain that there is no lateral stenosis, because that means that you will have pressure on the nerve roots during the standing and the walking. So I agree completely that we need to check for the free disc, the L5S1, why the normal position that this disc is having is hyperlordotic. It gives about 20 degrees of lordosis. So that means that for some reason, he's trying to compensate for some kind of kyphosis. Usually at the thoracic area, or as we can see here, the kyphosis starts from the thoracolumbar area.
Well, it starts with the L2 compression fracture.
Yes.
Good.
Do you believe that the L2 compression fracture happened before or after the fusion? This is a tricky question.
Because it's still, there's increased signal intensity still there on the sagittal T2. This is probably a more recent fracture.
Yes, we need to think that when we put these long screws, there is a kind of flexibility and tension of these screws. Even though we believe it is fused and immobile, there is minimal stress and tension for the screws, and a fracture can happen in between the fused vertebrae. It's very rare, but it can happen.
Yeah. So I think, my thoughts going forward here would be to get the scoliosis x-rays. If there is a primary deformity, you would need to address the primary deformity at the time. And then, when we look at why, I think from the MRI, she has pretty severe L5 foraminal stenosis as Vasilis was identifying due to the hyperlordosis there. So if we can get the lordosis to match better, so perhaps we would end up having to treat the primary thoracolumbar or thoracic deformity. And then we do need to do something to revise the fusion. The hardware needs to be removed. That extension of the right rod where it is going down into the pelvis, that needs to be removed. And again, if we correct the lordosis, get a little less lordosis through 4-5, we lost our imaging. Somebody made me host. I don't like being host. Can we get the pictures back? Can we get the PowerPoint back, please?
Imad, please. Imad is the host again. Imad,
Okay.
can you please give us the slides, the PowerPoint?
Who was the speaker? Who gave the case?
So can you see the screen?
Yes, we can see the screen again now.
Is the
Okay.
same case?
Yeah, it's the same case.
No, it's not
No,
the
this
same.
is the next case.
Oh, this is the next case? Okay.
Another case.
Okay. We can go on then. So, as I said, just to wrap up, I think you need to, for that previous case, that you need to address the pseudoarthrosis. You need to get the alignment better. And what exactly that would be involved, we need more physical exam history information and full length X-rays. So why don't you take over this next one, Ruli?
Do you think, Doug, that also
Okay.
case,
Sorry, go ahead, Giannis.
do
Oh,
you
Yanis,
think
okay.
also that cases must be incorporated in the new one?
Sorry,
Okay.
you were a little muffled. You were saying, do I think I need to do interbody?
Yes.
Yeah. So
Also.
basically, my rule has always been, in terms of dealing with the pseudoarthrosis, if you do the same operation, you're going to get the same result. Obviously, a posterolateral instrumented fusion here didn't heal. There's a bunch of potential reasons why you'd need to try and identify that. Start with basics, nutrition, vitamin D deficiency, nicotine use, all of that sort of stuff. Got to modify all of that. But then my feeling is that most pseudarthroses need interbody fusion because if they fail the posterolateral the first time, they're going to fail a posterolateral the second time.
And you need to identify the mechanical reason why this happens.
Yeah. Yeah. And again, addressing alignment and all that sort of stuff.
But mainly what you said, Doug, that you need to correct the primary deformity.
Yes. Yep.
They all avoid this.
And it's not mentioned yet the indication of the first surgery, the indication and the symptom of the first surgery, why it's done by
Yeah.
4 level. Yeah, it's not mentioned. Also, we need to find first
Yeah. Well,
indication.
yeah, we need more history. And of it, yeah, we basically need a lot more information to come up with a
Yeah.
plan for that. All right, why don't we go on again now? Really?
Okay. Yeah, this is the next case. History about 39 years old, previously healthy male who was involved in RTA in 2012 and was diagnosed with C2, C3 fracture, for which he got underwent ACDF C2, C3, anterior cervical decompression cage and fusion plate. 5 years later, he started to experience right side neck pain. Recently, he went to the gym and developed right side neck and shoulder pain relieved by tilt neck to the right and rubbing the muscle. The pain is mild to moderate with occasionally severe attack during car driving. Slide, please. On the examination, last physical examination last week, he looks unwell. He's noticed abnormal neck posture in the form of torticollis head, tilt to the right, no sensory motor deficit, power grade 5 in all limb. Hoffman and Lermit sign were negative. No other abnormality was detected. All systems are free. Follow-up CT of cervical spine showed resorption of the cage inside the C2 body with the plate and upper two screws displaced, and impact in front of the right C1, C2 with kyphotic of C2 and C3. Slide. Do you have the yeah, yeah. This is the X-ray imaging. Yeah,
CT,
absolutely.
yeah.
We get perception, yeah, of C2, and C2 is sliding posteriorly to C1, and the uh, cervical cranial junction is malalignment, and it. I think this movement and this posture will make narrowing of the foraminal, stenosis of the foraminal, and produce pain. But I don't know yet which foramen is more severe, left side or right side or both. Uh, and we can see the screw, the screw to the. I think it looks quite okay, the screw, but the it's move backward. Slide, please. You have another slide. Yeah, we can see this also, the resorption of the bone, and the fusion is not well, not established. Slide. Now we got the. This is only one question,
Yeah.
Mr. Iman. Yeah, okay. So this is three question maximum, but the question now still one question first. What are the possible approach to correcting this complication? Yeah, this is the question. Anyone want to comment, friends? Or maybe from me first?
Yeah, why don't you go ahead, Rudy?
Yeah. It is fail in front, but it's obviously there's a sliding craniocervical junction to the posterior, so and the bone is not good at the anterior part. So we have to do, in my opinion, we have to open and do the correction from posterior, and we put the stabilization from posterior lateral main screw and uh, tight it in the occipital cervical junction, and do a slight decompression, and then I hope it will correct the translation of the cervical.
Can we have
Hello?
on the screen the CT scan, the sagittal of the CT scan?
Yeah. Do you have the CT scan?
Yeah, it's
No.
the
Other
sagittal.
this,
The other one, the
the other
sagittal.
one, the complete one.
Yeah.
I mean,
This one.
Yeah.
This
So-
is not the complete one. Anyway.
Yeah.
oh,
So
on the,
this is again one where we need a lot more imaging, or see a lot more views of the imaging. It appears as though there's been a pseudoarthrosis that's mobile. It appears as though it has eroded both the inferior vertebral body, a significant portion of C3 and of C2. But what we need to know is we need to know about the C1 lateral masses, the C2 pedicles, pars, and then the lateral masses out further. Because you need to know where you can get fixation if you're going to correct this. This is one where I would give strong consideration to actually admitting this person before and putting them in traction, and then possibly re-imaging them in traction. Because if you need to know if that, and again, this is where more cuts of the CT scan would help you. If the C1, C2 joints are still mobile, and that this is just going through the bone, through the disc space, and probably through the C2, 3 facets, then this probably will reduce. The other worry I have here is because the lamina of C2 has stayed behind. I think this was probably a hangman's that has gone, and that the pedicles are probably gone.
There is very narrow space between the lamina of C1, the posterior part of the C1, and the posterior part of the body of C2, the lower part of the body of C2.
I think actually that's the body of C3 you're looking at there. I think most of the C2 body is missing here.
I think this is a cage.
You're seeing a cage, but
Yeah.
you know the screws would have been in the body of C2 and the body of C3.
Yes,
And basically,
it's
that
going
screw
up.
is right now. That's the upper screw is right now into the odontoid.
The C3 body is like a half, it's like collapsed, and you have the implant that is going into the spinal canal.
BL वाला 0813 7900 9387.
Somebody's should have their microphone muted.
0813 7900 938703. Uncle Habib de.
Dear Mahbub Khan, can you please mute? Yes, thank you. Yeah, I don't honestly know which part is the C3 and the C2.
Well, that's
but,
why I say we need many more cuts.
Yeah. At least the lower screws are still inside bone, but the upper screws have completely changed the orientation. They cannot have been put like that. So that means the whole upper part of the fusion has collapsed and was absorbed, as you said.
No, I again, seeing the C2 lamina is in line with the C3 lamina. I think that probably the index injury here was a hangman's fracture that they decided to treat anteriorly. It's gone on to a pseudoarthrosis. And so my guess is that that's what we would find on better cuts. There was a comment from the chat room about
MRI.
MRI to see. I'm not sure how much an MRI is going to add here. I think the CT, just having the rest of the CT available, because the C23 disc was dealt with it. That's where that cage went initially. So there would be no C23 disc to look at.
The only thing is to see the compression of the spinal cord. Nothing else. It's an MRI.
Yeah.
But I think after if it produces with the traction, I think someone must go front back, not only from
But
the back.
if it reduces with traction, I think this could be done posteriorly.
Yes, and only if you do a slight progressive traction and you see that this goes to a better position, then you just make a posterior fusion and you are done.
Are you sure that when you reduce that the implant will not compress? Because you see the body of the upper bodies perhaps will push the implant.
It's possible that you push the implant. I don't think it's likely, because as you're looking there, you can see the anterior portion of the implant. You can see the radiographic marker in the implant, and then there's that posterior wall of what's left of 3 there. So I don't think the cage would move. I think the cage is going to stay where it is. And if it does, I mean, you're doing traction with them awake, you're doing radiographs with them awake. If it moves, then you deal with it at the time. But I don't think it's going to, and I think you could probably just do this all posteriorly. The only question, and then I need to know how good the lateral masses are of C1. If there's good lateral masses at C1, I would try and do this as just probably a 1 to 4 instrumentation. If I'm not happy with the lateral masses and I felt I needed to go to the occiput, a lot of people now, and I think this is something to consider, are doing temporary occipital fixation. Basically go to occiput, and then once you have radiographic evidence of healing, take the occipital fixation out. It will gain them. They won't get full occipital cervical mobility back, but they will get some. And an OC fusion is just so debilitating that if you can do that, I think that's an advantage. If you can preserve the capital flexion extension at O1, I think that's a good thing.
Can I share my screen and show you an older story?
Sure.
Yes, sure.
Sorry. Can I?
We're seeing your screensaver really nicely.
Yes. Sorry, that was a mistake from my side. I wanted to move the cursor to the sagittal CT scan, but it's not in my computer, so it's a mistake. What I wanted to say, can we move again?
Put back the original. No, don't make me a host.
I unshare.
Yeah.
Maybe because I don't know how to use it.
Okay, here. There we go.
Okay, so imagine that during the traction, the upper part, the upper screws, the bony part will go maybe not in alignment with the lower part, but very close to that. That means that the posterior part of the C1 will come posteriorly, maybe not to align with the C2, but it will come posteriorly enough. In the old days, in the early 90s and the 80s, we used to take a bone graft from the pelvis and scratch the lamina of C2 and C1 and put it as a block in between the two laminas and put a wire. This was a French way of putting a fusion between C1 and C2.
I'm sure Brooks and Galley would both argue with you that they're not French.
No, not Rochely, but
yeah, but Galley described that in the 30s, and Brooks did it in the 50s.
I thought it was French. Anyway, I spent some years in Paris, so I thought it was French. This is where I was taught. And that means that even if the two lateral masses are not in perfect condition, there is space enough and enough surface to unite with and fuse with the pelvic block and avoid, if it's possible, the fusion with the occiput. But we need more imaging to do that, to see that and decide.
I think more slice from CT is better.
Yeah.
To do more slice.
Yeah.
Anyway, let's go to the third case.
There isn't a third case.
Oh, there isn't.
Are there any?
But I wonder though, if you do the traction, how long you recommend to do the traction before the next fixation of the instability?
I just because of my OR schedule, I'd admit him on Monday, put him in traction, do him on Thursday.
But can we do that without traction? Just do correct the instability.
You might
posterior approach.
You probably could do it. I just wanted to track again. If we had more imaging, it'd be easier to say. But this has been if this was a year old, I think it's probably more likely to be mobile. It seems as though there's been some sort of acute deterioration here. So there's again a lot of information we don't have. But I think that the idea of I like the idea of trying traction in an older injury because it's often stickier, and also it gives me an idea of what I'm going to be dealing with when I'm in the OR. If it moves relatively easily, that sort of leads me down one path of what I'm going to do in the OR. If you put him in traction and it doesn't even budge, then you're looking at a much different set of tools that you're going to want to use and techniques you're going to want to use.
Are you going to go how much high in kilograms for the back?
Sorry, how high do I'm hoping to only put
how many kilograms you go?
Oh, how much weight? Probably wouldn't go more than I'd probably go not much more than 10 kilos. And I'd start low. You start with 2.5 and go up.
You increase half a kilo every 2 or 3 hours. Very, very smoothly.
Yeah.
There are people that suggest even to 15 kilograms, 30.
Yeah, I think if with this, if it's not moving at 20 kilos, it's probably not going to move. You have to be careful how you do it as well. So this person would have to be flat in bed, no pillow, and you would have to make sure your traction is absolutely in line. If there's any flexion at all in your traction moment, you're not going to get any reduction here. So this is one where this isn't one where you tell the junior registrar or junior resident to go set up the traction. This is one, unfortunately, you've got to be there setting up the traction.
I remember one case you have, I think you Greg.
Also, and because this is a high cervical level, I think not more than 10 kilo is very wise, because it is high cervical level. And but the symptom, I think it's still minimal. The pain. What do you think, guys? It's still minimal, and I think it's from the stenosis due to the instability and subluxation.
So he from the sounds of the description, he's now developed a deformity that he didn't have. something acute has changed here on an acute on chronic. I think there's probably more than just he was working out at the gym and something happened, but he's not telling you the story because that's just an unusual history. In terms of, I think in acute trauma, a limit of 10 kilos makes a lot of sense in the upper cervical spine. In something that's been going on for a long period of time, you're not dealing with an acute ligamentous disruption here, and you could probably safely do more weight as long as you apply it slowly with them awake under controlled circumstances.
You have to think also that this is a deformity, a little bit stable, because the symptoms you have is more, it's pain. It's not neurologic symptoms. When you change, it doesn't have compression. So there is some kind of stability.
He will not do any neurologic symptoms at C2, C3, C1, C2. He will just, probably it has to do, the injury has to do with driving. That's why he mentioned that during driving he has problem.
No, I think this is
But
one.
at C1, C2,
Driving, he needs to turn to look. That's why he has more symptoms.
Yeah, there's.
When we drive, we change the position of our neck to see left and right, and sometimes abruptly. So perhaps that's why he has the symptoms.
I think though this is one to Ruli's comment. He's relatively asymptomatic right now, but this is not one that is going to get better or stay stable. This is going to get worse. And so I think this is one we have to do something.
now, not late.
Mm-hmm. All right.
All right.
I don't know. If we don't have anything else, do you have any questions to answer?
Great. All right, everybody. Thank you very much. That was fun.
Thank you very much.
Nice to see you all again.
Have a good week, everybody.
Thank you, everybody. Waiting all of you in Bandung.
Okay. Bye-bye.